Hello and welcome to Health Professional Radio. Glad that you could join us for another segment. I'm your host, Neil Howard. We'll be speaking with Dr. Jeremy Abramson, Director of the Lymphoma Program and the John and Joe Ann Hagler Chair in Lymphoma at Massachusetts General Hospital Cancer Center. Also the principal investigator of the study that we're going to discuss today concerning some updated efficacy and safety data for Seagen's ADCETRIS, presented at the 17th International Conference on Malignant Lymphoma. Welcome to Health Professional Radio, Dr. Jeremy Abramson. Thank you for taking the time.
My pleasure. Thanks for having me.
You are the director of the Lymphoma Program at Mass General. You're also the lead investigator of this study. Give us just a brief look into your professional background and then provide us an overview of the SGN 35027 study that you recently presented at ICML.
I'm a lymphoma specialist at Mass General. I take care of patients, and my research is in clinical trials. Mostly regarding aggressive B-cell lymphomas and Hodgkin lymphomas, particularly looking at novel targeted therapies as well as targeted immunotherapies. The SGN 35027 study is actually a three-part study, and I'm focused on part C of the study, which was what we recently updated at the ICML. Part C of SGN 35027 is looking at a population of previously untreated, non-bulky, limited-stage classical Hodgkin lymphoma patients. These are patients that have highly treatable, highly curable disease, and historically this has been primarily accomplished with a combination of chemotherapy and radiation therapy. But this is a young population of patients, often with mediastinal disease, and so we've been steadily moving away from the use of radiation therapy in these patients, particularly patients who have an interim complete response to chemotherapy. And that chemotherapy for decades has been the ABVD regimen. But ABVD, of course, has potential significant toxicities, including bleomycin lung injury from the bleomycin, as well as myelosuppression from the vinblastine. And we know from combinations that have previously looked at brentuximab as a replacement for bleomycin in the brentuximab AVD trial, that we do see encouraging efficacy with this regimen that omits the bleomycin in favor of the antibody-drug conjugate, but that we see significantly increased incidence of neutropenia, neutropenic fever, as well as peripheral neuropathy. And we think this is due to the overlapping mechanism of action of brentuximab vedotin and vinblastine, both of which target the microtubule and therefore result in bone marrow toxicity and peripheral neuropathy. So based on this, we previously conducted a study in non-bulky limited-stage Hodgkin lymphoma, omitting both the vinblastine and the bleomycin, and giving patients with non-bulky limited-stage disease brentuximab vedotin plus adriamycin and dacarbazine. This study is building on a prior phase 2 study we conducted also in non-bulky limited-stage Hodgkin lymphoma patients. In that study, we omitted both the bleomycin and the vinblastine and treated patients with brentuximab vedotin plus adriamycin and dacarbazine. That three-drug regimen induced a very high complete response rate of 97% and an impressive 5-year progression-free survival of 91%. Furthermore, we saw a dramatic reduction in incidence of neutropenia. There were no cases of neutropenic fever, and there was minimal peripheral neuropathy. And so based on that encouraging study, we decided to use the brentuximab, adriamycin, dacarbazine regimen as a backbone and add in the novel immune checkpoint inhibitor nivolumab to try and further augment efficacy with a reduced toxicity regimen. And this just three-drug regimen induced a complete response rate of 98% and a 5-year progression-free survival of 91%. Now, based on those encouraging data in a small phase 2 study, it was hypothesized in the SGN 35027 Part C study that using that backbone of brentuximab, adriamycin, and dacarbazine and adding the immune checkpoint inhibitor nivolumab might help augment efficacy in non-bulky limited-stage Hodgkin lymphoma patients while continuing to omit potentially noxious agents, including bleomycin, vinblastine, and radiation therapy. And so this study particularly looked at a population of 154 patients with non-bulky limited-stage Hodgkin lymphoma, and treated all patients with a total of just 4 cycles of treatment.
And what were the findings from this study, and give us the significance of those findings?
We saw a very encouraging overall and complete response rate with 150 evaluable patients. The overall response rate was 98%, and the complete response rate was 93%. Not yet presented the time to event analyses, meaning the progression-free survival, but we are hoping to present those data at the American Society of Hematology meeting this coming December. We saw all patients had dramatic reduction in their tumor burden with a very high complete response rate, and we found that this treatment was extremely well tolerated. The incidence of peripheral neuropathy was low, and particularly the incidence of grade 3 or higher peripheral neuropathy was only 3%. We also saw a low incidence of neutropenia. In fact, only 12% of patients developed any grade neutropenia, and there were 0 cases of neutropenic fever. And so this did appear to obviate the bone marrow toxicity that had previously been observed with the brentuximab AVD regimen.
Obviously, this is going to be a great improvement for patient outcomes in the future. Which specific patient outcomes are going to be improved the most, in your opinion, based on the data?
Well, I think currently these data are a little too immature to know if they're ultimately going to be practice changing. I think right now what we can say is that in a large population of non-bulky limited stage Hodgkin lymphoma patients, that the efficacy of this regimen is extremely high in terms of complete response rate, but ultimately we'll have to assess the durability in terms of progression-free survival to understand how this regimen moves forward. We can also say that this was a well-tolerated regimen. It omitted a bunch of the toxicities seen with previous historic chemotherapy regimens, and with a low incidence of immune-mediated adverse events, which is something we look at when combining with an immune checkpoint inhibitor. I think ultimately, if these data continue to look promising in terms of durability of response and progression-free survival, then hopefully this regimen could be compared to a more standard chemotherapy-based regimen in both advanced stage and limited stage Hodgkin lymphoma in a randomized trial.
What are the goals of treatment for Hodgkin lymphoma patients, given that adolescents and young adults are primarily affected? And give us any final thoughts that you'd like to share in closing.
You know, the most important element of treating Hodgkin lymphoma is to cure the patient. And this is a highly treatable, highly curable disease with a vast majority of patients achieving cure. And obviously, in a disease that affects young people, that means decades and decades of life ahead for these patients. So the number one issue is to cure the patient. But remembering that there are decades of life ahead, we also have to very seriously consider minimizing the short and long-term toxicities associated with our treatment. And that means moving away from radiation therapy, which induces long-term risks of heart disease, lung disease, and secondary malignancies. It means reducing the incidence of peripheral neuropathy, which can be a lifelong impediment to patients' quality of life. And in the short term, it means minimizing the risk of serious infections, which can be life-threatening. And so I think this regimen has the potential promise to optimize the cure rate for patients while minimizing toxicity by really leaning in on the novel targeted therapies of brentuximab vedotin and the immune checkpoint inhibitor nivolumab, along with just 2 core chemotherapy drugs, adriamycin and dacarbazine. And ultimately, I think as a field, we need to continue to move away from old-fashioned, more toxic chemotherapy regimens and radiation in favor of more targeted therapies to optimize the cure rates and reduce toxicity.
It's been a pleasure speaking with you. Lots of great information. I'm hoping that you'll return because we haven't even scratched the surface, and give us some more information as things progress.
That'd be my pleasure. Thank you for having me. I enjoyed talking with you.
You've been listening to Health Professional Radio in conversation with Dr. Jeremy Abramson. I am your host, Neil Howard. Audio copies of this program are available at healthprofessionalradio.com.au. You can also find us on Anchor, Spotify, and be sure and subscribe to our YouTube channel at youtube.com/Health Professional Radio.